I think we'll go ahead and officially get started. Good morning, everyone. This is our February 6th already. I can't believe we're already that far into 2020. Our fourth ECHO session, so welcome everyone. So happy to have you here. This morning, again, our reminder of our data usage notification. We're asking you all to sign in and share your information because ECHO is going ahead and they measure and analyze how many people are joining, the topics that we discuss and things. So I always want to make sure that we're aware of our data usage notification. And any issues with Zoom or anything, please, go ahead and put it in the chat box and we'll go ahead and help you if you're having some trouble with video or with audio. And as I was saying, we love to see your smiling faces, so go ahead and put your video on. I understand that it's early in the morning, you may be having your breakfast, your coffee. That is all completely normal. I've got my coffee here too in Tinkerbell. So please enjoy your breakfast and coffee as we have this discussion and session this morning. So just some audio pieces. The one thing that I want to say is go ahead and use your chat if you've got anything that you want to send to us. There's a note there that says to everyone. If you don't want everyone to see it, then you'll have to pick ICSI to send it specifically to us. So this morning, what I wanted to do is call out our participant organizations, and what I'd like you to do is kind of just say good morning so we can see who's on. What happens is we've got our core hub subject matter expert organizations. Those are our Minnesota Health collaborative organizations that have been working with integrated behavioral health and primary care for well over a year and a half. It's closer to over 2 years at this point. And I'll call out your name and then can you just say good morning? Allina Health.
Good morning.
Good morning. Children's Minnesota. I don't think Julie was able to join us today. Hennepin Healthcare. Health Fairview.
Good morning.
Good morning. North Memorial.
Hi there, it's Jessie.
Morning, Jessie. Sanford Health.
Good morning from Sanford.
Good morning, Jeff. And then our SPOKE are our learning organizations. These are ICSI member organizations that have come new into the IBH work to join this conversation. Folks from Community Health Services, Inc.
Good morning.
Good morning. Entire Family Clinics. I can see Ellie's going, I don't have any audio. Okay.
Good morning.
Good morning. Fairview Masaba Clinic in Hibbing. I was just talking with her, so I know she's out there.
I was going to say, yeah, Jamie is on the call, I thought.
Yeah, Jamie's on the call, but good morning, Jamie. We know you're there. Lake Superior Community Health Services, Christy.
Good morning.
Good morning. Open Door Health Center.
Lisa's here this morning.
Hey, good morning, Lisa. And Ortonville Area Health Services.
Good morning.
Good morning.
Sarah.
Good morning, Sarah and Twyla. Thank you so much. So those are our folks that are represented today. What we're going to do is we're going to go ahead then and jump into our educational or didactic piece. And this morning, we're going to hear from Laura Nielsen from Health Fairview, and they're going to talk about evidence-based treatment in primary care. And this will be based on the cross-model IBH framework and the work that's being done at Health Fairview. Laura, why don't you go ahead and introduce yourself and just let me know when you want me to move your slides for you, okay?
Wonderful. Well, thank you so much for asking us to do this presentation this morning. So again, my name is Laura Nielsen. I am a manager with our system clinical integration team here at Health Fairview. So I have responsibilities for supporting embedding behavioral providers into primary care and specialty medical services via the role of the BHC, or the behavioral health clinician. And I also have responsibilities for our behavioral health home services. And as Jeyn said, I'm going to talk today about using evidence-based treatment. So I think you can advance to the next slide. So I have no disclosures. So Jeyn asked me to do just kind of a quick 30 seconds of who we are. So some people may have noticed this is a new name, Health Fairview, which represents the newly expanded collaboration amongst the University of Minnesota Physicians, and Fairview Health Services. Some people may be aware that Fairview and Health East have been in an integration process over the last few years. So the former Health East clinics also now have that Health Fairview name. So our healthcare system combines the best of academic and community medicine, expanding access to world-class breakthrough care through our 10 hospitals and 60 clinics. You can advance to the next slide. So I thought I'd just give a brief overview of our outpatient services. We also have a newly named service line, which is the Mental Health and Addiction Service Line. It is made up of both inpatient and outpatient services, but I thought for the purpose of our presentation today, I'll just give you a quick overview of what we have for outpatient services. So of course, I'm here speaking on behalf of our primary care integrated behavioral health services. We also have specialty mental health services, collaborative care psychiatry services, addiction medicine services, substance use disorder services, mental health programs that include things like day treatment, dual diagnosis, our 55+ intensive outpatient programming, and partial hospital programming. And we have a fairly newly launched mental health and chemical dependency assessment center. Advance to the next slide, thank you. So again, today, I hope this is helpful for the group, but I thought I'd talk a little bit about some work we've been doing over the past year on training our BHCs in evidence-based practice. So the objective today is to learn how we've partnered with the Fairview Sleep Center's insomnia program to develop a primary care model of treating insomnia and training our behavioral health clinicians in using CBTI. Next slide. So just to give you a little background on kind of how we got to where we are today. I can't take credit for the idea. We were actually approached by the lead sleep psychologist, Dr. Mike Schmitz from Health Fairview Sleep Center Insomnia Program. And he really came to us with this vision, with this idea to try to better meet the needs of our patients in primary care who are presenting with insomnia by providing ready access to CBTI. Because kind of more traditionally, more common, patients were getting referrals to specialty sleep services, and as we know so often with specialty services, it's oftentimes it can be a 6 to 8 week wait, or sometimes maybe even more. And his idea was to look at how do we take a little bit more of a systems-based approach to this. His vision was, instead of just continuing to hire more specialty providers in the sleep program, he really was interested in looking at, kind of partnering together with what's happening in primary care. And so I said to him, like, fantastic, this sounds like such a wonderful idea, and would you come to one of our BHC meetings, and let's see if we might have a BHC or two who'd be interested in helping us pilot this, and then see what we might learn and kind of go from there. He came to one of our BHC meetings. He talked about his vision, his idea, and we said, who's interested? And everybody's hand shot up. So the whole team was interested, and it made sense. We know that so many of our patients struggle with sleep, and the BHCs all said boy, why wouldn't we take this opportunity to get more training, to get more support, to have more tools to better support our patients. So we can advance to the next slide. Thank you. So why would we do this work? CBTI is recommended by the American College of Physicians as first-line treatment for chronic insomnia. It's also a proven non-drug behavioral treatment for chronic insomnia, and it is safer and more effective than sleeping pills in the long term. So we know it's not uncommon when patients come in that oftentimes they're asking about medications, but this really is what's recommended as kind of the first-line treatment. And so why did we do this? Why did we choose to do this in primary care? Because we also, I mean, we have behavioral providers kind of across the whole continuum, and we explored different options like, oh, do we train our specialty mental health providers? Do we do our BHCs? And it really just seemed to make good sense to offer this service in primary care, help support quicker access to services, help support a stepped care approach to treatment. And I had kind of a, oh, sorry, I thought I was getting a question, but maybe not, maybe just background noise.
Yeah, okay.
And so anyhow, I had kind of a fun example the other day of, it's performance review time here, so I'm doing a ton of chart reviews, and I was doing a chart review, and the patient, I could see there was insomnia, sleep difficulties, and it started off with him sending a my chart note saying he was just struggling terribly with sleep, was really distressed, was really having a hard time. He had an appointment a couple months out at the sleep center, but had seen a flyer in the clinic about the BHCs being able to do CBTI. He wondered, you know, if he would be a candidate for that, and he was scheduled for an appointment within a few days and was able to get started with getting help right away within primary care. So that was kind of neat. That's why we're doing this. Ideally, we're also working on, it's great when our patients see that, and we're also working on, you know, kind of how do we change practice so that maybe that referral would have been given right away versus kind of after the fact. Can advance to the next slide. So how have we done this work? So of course, you know, we really needed to start off with just really good training. And so it actually was about a year ago, January of last year, we put all our BHCs into an all-day training on CBTI. And then, you know, and that was facilitated by Dr. Mike Schmitz, who's just really an expert in this area. And then he periodically comes to our BHC meetings if there's new information, to check in how things are going, if he has kind of additional, you know, additional training to provide. With our next meeting in 2 weeks, we'll be doing a kind of a half-day training on to just kind of elevate the training that they have to include, you know, kind of brought into some new areas. We do weekly case consultation and support. So BHCs can call in if they have questions, kind of challenging cases, and Dr. Schmitz is always available on those calls to kind of help talk through the conceptualization and the recommendations. And then he's amazing. He's available to our team really anytime there's questions about the care of the patient. Of course, another important part of launching a new service like this is educating the care team about what we're doing, why we're doing it, who would benefit, and then generating referrals. And then I think just kind of foundational to anything that we do is having support from leadership, both primary care leadership and our mental health and addiction services leadership. So that was just an important part of piece, kind of bringing them into the fold with what we wanted to do and making sure we felt like we had good support. I can advance to the next slide. So this next slide is a little bit on future dreams. So I think because we've been doing this for about a year now, we did a reflection kind of last November, December to say, you know, what have we learned over the past year? What do we think went well? What would we change in the next year? And we did have quite a few things that we decided, you know, I think that we are changing moving forward. Some of it that we've decided to do is to kind of formalize participation requirements for case consultation, just because that's really where, you know, we're able to get a pulse on how the BHCs are doing with providing care, and they're able to help kind of demonstrate, you know, their competency. So we're going to have requirements around attendance, and then doing formal case presentations. We're adding an exam this year. Last year we did kind of like a pre-test, post-test, which was nice to say like, oh, what'd you think before the training and what'd you learn from the training? But this time we'll actually have a test/exam, if you will, where we'd look for them to get a certain score to pass. Will continue to be required that, like, so if new BHCs want to be a part of this, they'd have to attend the full day training and the follow-up half-day training. So we have several new BHCs who are coming on board, so our you know, aspiration would be to get them trained as well. We're also looking at having a couple of our BHCs be CBTI champions to just kind of help, you know, provide their leadership in this arena. And then we've also thought about the idea of, you know, does it make sense to also see if we might be able to identify some primary care providers who would be champions of this work with us to, again, you know, help represent our partnership and work together. And I've lost track of time, so I don't know if I've I may have gone over, sorry, but yeah, I guess we just end it with any questions for me?
Well, thank you, Laura. Questions for Laura. You can unmute yourself and go ahead and ask questions. Realizing that the use with insomnia is a bit different than what you might envision for integrating behavioral health into primary care. However, it's a very, very important part of behavioral health and mental health care is sleep. So calling that out. Any questions or thoughts about the piece that Laura has shared with us?
Hey, Laura, this is Jeff from Sanford Health. Thanks for that presentation. That's a lovely example of bringing a specific skill set into primary care. So congratulations on that. My question is this. I'm guessing that there's a subset of patients with insomnia who have underlying more serious behavioral health problems, depression or nightmares related to trauma, or maybe some kind of relational incompatibility with their bed partner or something like that. I'm wondering, is that something that the BHCs would address in conjunction with kind of this manualized treatment, or do they get referred back to specialty mental health, or kind of how do you handle it when you see that there's some other issue in the room that might need to be addressed that's contributing to the insomnia? Thank you.
Yeah, great question. And can I give my favorite answer? It depends. No. So that is a great question. And, you know, one of the things that we have learned with this, so of course, you know, a huge part of the training is, you know, how do you screen for insomnia and other potential sleep disorders? How do you determine who really is a good candidate for CBTI, whether it's now or later or not now, and they really need to go to specialty sleep services? And we've got a huge algorithm around that. And so part of it is, you know, that good assessment to say, you know, what else is going on from a mental health perspective. And so it does somewhat depend upon all those factors. It could be that, you know, the answer is, or the recommendation is, we need to do some work on stabilizing some of those other factors first. It could be that, you know, even in spite of some of those things, they still could benefit from CBTI, which might actually help with, you know, some of the other difficulties that they're having. But I think, you know, when I listen to these wonderful, you know, case consultation questions every week, I mean, I think what we realize more often than not is that very rarely is it straightforward. Most often it's, you know, it's complicated, and people are, you know, being really thoughtful and getting consultation and trying to figure out, you know, what's the best pathway or approach. But as Dr. Schmitz always reminds us, you know, these nice protocols were developed, you know, with, you know, just really basic, like they're able to find people that just have, you know, kind of an isolated problem. And the reality is, in primary care, it's oftentimes much more complex than that.
Thank you. Any other questions out there?
This is Mirza from Allina Health. We actually had a CBTI program at one point, but then we prioritized suicide prevention, and then we essentially dropped it. We do have some sleep psychologists doing CBTI though. But my question for you, just out of curiosity, is how do your BHCs balance their different duties in primary care with CBTI?
Yeah, so I think, you know, I mean, by and large, I mean, it's just like I mean, every day is a bit of a, you know, you're juggling and balancing, right? And you never quite know kind of what's going to walk in the door and what the needs are going to be. So I would say with the BHCs doing CBTI, I mean, I think the volume hasn't been overwhelming. They've been able to, you know, manage it within kind of our current structure, where, you know, a good chunk of the day is spent in billable activity, and, you know, we're intentional about keeping some of the day free so that they're able to do, you know, other important aspects of the role that are non-billable.
Thank you. I'd like us to move into our case presentation at this time. If you have additional questions about the didactic or education piece, we can grab those at the end. So please put a pin in that. We're going to move forward. And before we move into the case presentation, I just wanted to remind you all about kind of the ECHO process. So what we'll do is we will have Christy Hills of the Lake Superior Community Health Center is going to present their case presentation. And during that time, she'll present, and then what we'll do is we'll go into what's called clarifying questions right after her presentation. Are there other questions you have for her that might not have come up in the discussion that would add to how we would secondarily then add recommendations and have that further discussion? So clarifying questions first, and I will go to those folks on the phone, and then I go to our core hub folks, or those subject matter experts after that. And then after we do clarifying questions, we'll go to recommendations, and we'll follow the same process. But just to kind of give you an idea of what to expect as we move forward. So without further ado, I'm going to ask Christy to go ahead and start sharing her case presentation and a little bit about Lake Superior Community Health Services. Christy?
Good morning. Thank you for having me present today. So if you want to go to my next slide, and I'm sorry, the next one where I have my, yep. So Lake Superior Community Health Center is a FQHC, or federally qualified health center, in Duluth, Minnesota, and Superior, Wisconsin. So we work in both states. Our federal requirements are to provide a sliding fee scale and income-based payments for our population, and we provide medical, dental, behavioral health, and healthcare access in both of our locations. We have 3 clinics, 2 over in Superior, one of which is primarily behavioral health and substance abuse treatment, and 1 primary care clinic with medical and dental and behavioral health. In Duluth, we provide just the medical, dental, and behavioral health, and then healthcare accesses at both. The real focus of our services are to make sure that we are providing services to uninsured or underinsured populations. We have a high percentage of patients who experience a lack of resources for basic needs such as housing, food, primary care, dental, and I already discussed our clinics in both Duluth and Superior. Next slide, please. The clinic in, oh, I already covered all of this as well. Okay, next slide, please. So really what I'm looking for today, or what we're looking for today, is working towards more consistency between our two clinics and really where to start that process. Within the past 6 months, I've been placed in charge of the Superior location for behavioral health and substance abuse. And there are differing systems in the Duluth clinic versus the Superior clinic, the primary care clinics, that I would like to make more consistent and change. However, I really don't know where to start. And how can we better utilize IBH in our clinics? So in Duluth, we really have more of an on-fly consultation between providers. We have 2 behavioral health clinicians and myself kind of embedded in the medical hallway with our primary care physicians. We will join other sessions, each other's sessions if necessary. If a medical provider feels that they need assistance or they have someone in the room who would benefit from behavioral health, they'll kind of come and grab us if they can, if we're available and not with clients. And we try to do that in between that 15 minutes between sessions. So either at the top or the half of the hour, medical providers will come and the MAs will come and grab one of us, or we'll make ourselves available if we have cancellations. I've worked really closely with the primary care physicians in the clinic to, build relationships and provide suggestions for de-escalation and kind of those more crisis type situations. And then we also often consult afterwards about what we feel would be the best route of treatment. In Superior, we have 2 clinicians who are not in the same hallway as the medical providers. They're off on their own in a section of the building. And they do have scheduled IBH time where what's often happening is our front desk will schedule clients who call for same-day appointments. Often they don't have a diagnostic assessment done, and sometimes this is utilized not necessarily for crises, but more for people who don't want to go through a full diagnostic assessment. Our medical providers are not feeling as comfortable utilizing those time slots, and often I hear feedback that one of the clinicians isn't very open to collaborating, and also that when they need the behavioral health providers, the time slots that are scheduled are not when they really need people, because it's not schedulable. You really can't schedule when someone is going to need to step in. So some of the barriers to care, patient barriers, include insurance and billing, having behavioral health providers available, and the clinician's openness to be flexible and assist the medical providers as needed. Next slide, please. So I'm really looking for some recommendations. I'm relatively new to IBH, and that's just kind of where I am right now. It's really brand new for me. So I'm just trying to kind of wrap my head around what it would be the best way to get something more consistent across the 2 sites.
Well, thank you so much, Christy. So just at a high-level summary that I will put out to the group, and just if it's off, we'll correct it. If not, we'll continue forward. So what I think I heard was that within your clinic system, you have 2 different setups going on in Duluth and Superior, and really looking for the opportunity of where can I start to move IBH further faster, and for consistency and uptake and buy-in with the other providers. Mm-hmm. And really looking at the give me some pointers of where can I get my feet on the ground to better utilize schedules, and or maybe schedules I read between the lines and said maybe schedules need to change a little bit or something needs to happen. So really that's kind of that really high umbrella is what can this group now ask me for clarifying questions and then get to recommendations. Is that fair, Christy?
Yep, that's fair.
Okay, awesome. So at this point, what I'd like to do is I'm going to stop sharing the PowerPoint and I'm going to go into looking at everybody so I can see if there's anybody that wants to ask a clarifying question, go ahead and you can wave at me or you can unmute yourself and go ahead and ask clarifying questions. So let's ask clarifying questions to Christy so that we can get to a better understanding of the situation. Questions?
I have a clarifying question. This is Catherine Charlo from Allina.
Yes.
So I have experience in both leadership of a psychology region, which would be mental health providers that are in primary care clinics, but perform their duties on a compensation-based model that's based on RVUs, so production. And now I also have a significant number of years of experience leading our mental health consultants, which are a salary-based, non-production model of integrated mental health and primary care, a program that is expanding quite a bit. Looking at your comp model, and I don't want to ask any, personal questions about your facility, but when you look at your comp model, one of the things that you may want to consider is that any providers who are on a production model have a pressured situation in terms of filling their time, and the collaborative care is generally not in the production model. So it can be a comp issue that can be difficult to overcome.
Sure. All of our clinicians are on salary-based reimbursement.
Oh, well then integrating should then be a function probably of flexibility, willingness, and interest, as well as the way you structure the schedules. Those 15-minute gaps between have been really helpful for the mental health consultants at Allina because it provides a time for rounding and catch up. But I will say that one of the things you could also look at is the way in which those 15-minute gaps are used and whether your providers are able to end the face-to-face time with patients to go on and do the integration between sessions. You may look at gapping it differently, maybe adding a little bit more if they're not able.
Okay. And it seems to be working pretty well over in Duluth without the real formal schedule. The medical providers in Duluth really do utilize behavioral health on a pretty high level, and we end up getting a lot of referrals out of those interactions. Superior, it feels much more like team-based work where we're really working with the medical providers, and even some of the dental providers have started to utilize us over in Duluth as well. We're running into a bit more siloed feeling over in Superior.
Thank you both. Other clarifying questions, and it's so hard to not run into recommendations. So clarifying questions, is there more information we want to draw out of Christy right now? Ellie?
I'm just wondering, do the medical providers in Duluth?
You probably have your phone and your computer on, just one.
Go ahead.
Sorry, I'm just wondering, do the medical providers in Duluth and Superior collaborate?
Yes. We have, there's a monthly provider meeting, and then we also do a monthly curbside psych consultation with one of the local psychiatrists. So twice a month, they're meeting as a group.
Christy, this is Jeff from Sanford. I apologize if this question is too simple, but just based on the brief presentation you gave, the question I had is, to use a Minnesota kind of metaphor, is there anybody else that's going out on the ice with you as far as trying to change the culture in Superior? In other words, are there any other allies or partners other than you that's trying to change the way things are functioning in the Superior clinic, which seems to be a little lagging behind the Duluth clinic?
Our medical director is very supportive of doing more IBH, and she actually works in Superior and has built some relationship with the clinicians. And I think our CEO is definitely on board as well. And my clinic manager, my behavioral health clinic manager, is definitely on board. So I really need to get the clinicians on board. I have higher level support, but I need the actual individuals doing the work to be more on board. One of the clinicians is very much on board, but he likes the, there is a model, and I'm sorry, I'm blanking on is it the Chattanooga model for IBH? Is that correct? Does that sound right? And that isn't feasible in our clinic. And so he's kind of grabbed onto that and wants to do it that way. If I'm saying that correctly.
Another clarifying question: is there a decided upon model that you just touched on? This one provider has a favorite type model. Is there a model that your organization has discussed and decided on to guide this work?
No, we're really at that preliminary stage right now, where those decisions are being made.
Okay.
And it may be that we need to move a different provider into the Superior Clinic who would be more on board with doing this type of work. All of those things are options right now. It's really at that very beginning stage.
Okay, thank you. Other clarifying questions?
Why, this is Mirza from Allina Health. Why is the model not feasible in the Superior Clinic, the Chattanooga model?
The model is not feasible for either clinic due to billing, because the state in which developed that model has a different setup for their Medicaid billing. And while we are very much about providing a service to the community, we also need to consider reimbursement, and that model wouldn't support sustainability of the program.
Thank you. I need to move us into recommendations. So let's move into recommendations. We've heard a lot, and we kind of slipped into those a little bit. So recommendations for Christy and the clinics. What would we like to start with?
Well, I actually had one question. It could turn into a recommendation based upon the answer, but I guess I was just kind of curious, intrigued by space and where the providers are placed, and if there's been any discussions on moving them closer to the team.
No, we have not had any discussions about moving offices.
So I guess I could turn that into a recommendation then. You know, we find, you know, really having our embedded behavioral providers elbow to elbow with the primary care providers, it facilitates collaboration, consultation, you know, pulling the BHCs in for warm handoffs. And we also encourage that they, you know, kind of move around throughout the day so that they're kind of having exposure to the whole care team. But I would see that as an important piece of getting them, you know, closer to the people that they're working with.
This is Twyla in Ortonville, and I'm gonna echo what she just said. As a mental health provider that's embedded in our primary care clinic, initially when I was farther away from the team, there was less collaboration, because if they don't see you, they don't think of you necessarily in that moment. So I would echo trying to embed your provider within the clinic where the other clinicians are, will help to kind of build that collaboration and that relationship between providers to include behavioral health.
Thank you. Other recommendations?
This is Mirza from Allina Health. I personally think that you need to standardize what the two clinics are doing and actually move Superior closer to where the Duluth clinic's processes are. that's going to be a big challenge for you. And you need, as I think Jeyn said earlier, you need to get buy-in from providers. And you need to get it across the board, essentially. And so there's probably a sort of kind, assertive way to do that over time. And people need to understand why you're making that change and try to motivate them to make those changes. But it'll take some time, it'll be difficult, but I would also be assertive on making those changes. And I think it would work better when you standardize both clinics in the future.
Mm-hmm.
Thank you.
This is Laura again. I'm curious, I really like that suggestion. Have you thought about having the behavioral providers from Superior do any shadowing of the providers in Duluth, or the people who you think are doing the model well? Because I know that's been a helpful part of anytime we start new providers. You know, they go through about a month of training and orientation, of shadowing people who are doing the work. And I guess I also appreciate your challenge or struggle, because I feel like, you know, I have the luxury of, I hire new providers into this model, right, versus kind of changing how somebody has been practicing. But I think an important piece of that is for people to understand what is integrated behavioral health, and do they want to do it? Does it interest them? And I don't know what it's like in your system, but in our system, typically, like if integrated behavioral health isn't, you know, somebody's cup of tea, you know, we can get them, you know, connected with specialty mental health services or a position that feels like a better fit.
Mm-hmm.
But it's a challenge if you've got somebody who maybe isn't really interested in doing the model.
That's thank you for that. It's interesting because the one clinician who is a little less flexible about things really wants to stay in the clinic, but doesn't necessarily want to be a part of IBH. She doesn't want to be moved over to the behavioral health clinic. So it's there's some challenging situations. The clinicians I have in Duluth are newer to the field, where the two in Superior are more established, and kind of having more of that independence for several years, where my clinicians in Duluth, I'm training and teaching. And so that makes it a lot easier to kind of, for lack of a better way of put it, mold them to appreciate the wraparound care that we can provide when we're embedded in the clinic.
Christy, this is Jeff from Sanford. I think these are all great ideas. The one thing I would encourage you to think about is whether what you're dealing with, what we call a technical fix or an adaptive challenge. You know, a technical fix is like the light bulb burned out, so we just need to put a new light bulb in, and pretty much everybody agrees that that's how you fix it. There's no conflict, there's no emotions that run high with putting in a new light bulb. An adaptive challenge is when you have to change hearts and minds. Mm-hmm. And I'm not clear from this very brief presentation if you have an adaptive challenge in the Superior clinic, that there are some hearts and minds mm-hmm. that need to be changed about why you're doing this. And one of the things that I've come to believe about leadership is that all systems are strategically aligned to get the results that they're currently getting. Mm-hmm. In other words, things are that way in that clinic because that's the way people want it to be right now. Mm-hmm. And for you to change that culture, I think is going to require, you know, what we call mapping the system. In other words, you need to know what the values, the loyalties, and the losses are for every person in that clinic that plays a stakeholder role. Mm-hmm. What do they value? Who are they loyal to? And what do they perceive losing? Because in my experience, it's not that people resist change, they resist loss. Mm-hmm. And so it makes me wonder if some of those people who are dragging their feet are doing so because they have the perception that they'll be losing something. Mm-hmm. And so I would just encourage you to be just mindful that before you start changing the light bulbs, metaphorically, that you be clear on, is this just a technical problem that we just haven't done anything, haven't tried anything, or are there some fundamental underlying resistances that you need to be aware of? Because if you're not, then it doesn't matter what you do because it won't stick. And maybe you've already done that. So I apologize if I'm taking us down a rabbit hole, but that would be my advice to you.
I appreciate that. And I have kind of preliminarily taken the temperature of the clinicians. And like I said, I know that I have one that's on board because he's very supportive of IBH. It's just a matter of kind of selling him on what the model is and getting him to come on board. And the more we talk about this, the more I'm feeling like I'm going to need to move a different person into Superior and make some hard decisions in locations.
This is Catherine Charlo from Allina Health. The one other thing I would say is having a primary care champion from the medical teams can be extremely helpful. And I had combined my question kind of before with a couple of recommendations, so apologies on mixing the two talk times. But the only other thing I wanted to say is that from a really interesting training I went to in 2015, one of the things they really helped us understand is that model adaptation can be really difficult, and sometimes you do need to make those hard personnel decisions. But we've definitely found at Allina that it's very helpful if you have primary care champions who are medical side really invested in this, because I think it helps the comfort level of everyone.
And fortunately we do have that, because both of the medical providers in Superior also provide medically assisted treatment for our substance abuse program, and they work really collaboratively with us and my substance abuse group. So I don't feel that that will be a barrier, fortunately.
Thank you. Any last recommendations to share with Christy?
This is Laura, and this may sound really basic, but I've found this to be a really helpful piece of, when we're launching this model in new clinics, is just really getting in front of the whole care team and, talking about, why we do this model, how it helps serve our patients, what the benefits are. And oftentimes I feel like the response is so positive that people are like, oh my gosh, yeah, why wouldn't we do this? But so anyhow, that I don't know how much you've had a chance to kind of get in front of all the providers and really talk about the model and the benefits, but that might be helpful as well.
Thank you.
Awesome, thank you so much. At this point, what I'm going to do is I'm going to ask Gretchen to go ahead and give us a summary of the recommendations that we've heard, so we can hear them, and if there's anything we need to change on them, we'll get them adjusted. Gretchen, can you share the recommendations that you heard?
Yeah, so first, overall, we discussed moving physicians around, so having the BHCs and primary care physicians elbow to elbow, move them throughout the day so they have exposure to the whole care team, and kind of do a physical integration of the behavioral health and medical providers. Several people echoed that. There was also a discussion about standardizing what the two clinics are doing. And then one example of a way to do that might be to have the behavioral providers in Superior shadow the ones in Duluth that are doing it, this model well. And then a key recommendation was to consider whether this is a technical fix or an adaptive challenge. And it sounded like maybe there was some adaptive challenges here where there's some clinicians, or maybe one clinician in particular that just doesn't feel like IBH is a good fit for the way that they want to practice. And so thinking about how to be true to the model and also true to personnel. Having primary care champions and having administrative champions, it sounds like really having the whole team on board is going to be a key recommendation. And getting in front of the whole care team to explain how and why the IBH model is beneficial to patients.
Awesome, thank you. From that recommendation summary, anything that catches anyone's ear that needs to be tweaked a bit or anything that needs to be added? I don't see anyone waving at me and I don't see anything coming up, so, okay. Thank you. Any questions back to our education or didactic piece? Anything else that's come to mind for the group today?
All of these expos have been great, but to me, this is the best one so far.
Awesome. I'm excited by that. Well, you know I am. So here we go. Very good. Thank you, Mirza. And I think as we're wrapping up today, general announcements for us are that we have an evaluation that we'll send out by SurveyMonkey after this one. We will be sending you out the PowerPoints. We will be sending you out the notes as far as the discussion went today. And we will also be preparing for our next event, which will be March 10th. And that will be, the Hennepin Healthcare will be presenting from the education or didactic piece. And then Ortonville Area Health Services will be presenting the case presentation next time. As we wrap up, any last thoughts or comments to be shared today? You can just unmute yourself if you'd like to say something. Awesome. So thank you all so very much. Looking forward to getting the information out to you from this session and looking forward to our next session on March 10th. Thank you. Everybody have a great day and wonderful afternoon as well. All right. Bye-bye.
Thank you.
Thank you.
Thank
Bye.
you.
Bye-bye.